Yeah, we are live now.
Okay. So, good evening to all of you, and good evening, Dr. Anuj Maheshwari, for accepting our invitation to speak on hydroxychloroquine. So, today we have two talks. One is on inflammation and diabetes, the link, and second is on role and relevance of hydroxychloroquine in type 2 diabetic management. So, we have two speakers. Dr. Anuj Maheshwari will be speaking on inflammation and diabetes, the link. Dr. Anuj Maheshwari is a well-known personality as far as the diabetes field is concerned. He is a vice president in RSSDI India, and he is a professor in medicine in
Babu
BBD
Banarsi Das University.
University, Babu Banarsi Das University, Lucknow. So, without taking much of time, my request, I am inviting Dr. Anuj Maheshwari to moderate the session as well as to speak on inflammation and diabetes, the link. Please, sir, this is all yours, sir.
Thank you. Thank you, Upendraji, for this nice introduction, and thank you, IPCA and all who has organized this webinar. And I shall be talking about role of inflammation in the diabetes and how does this inflammation works when diabetes occurs. And my co-speakers will be telling about hydroxychloroquine and how can it really help in management of the diabetes. So let me share my slides first. So hopefully all of you can see my slides. Can you see my slides? Anybody would
No, sir.
confirm?
No, sir. No, sir.
No?
No.
Okay, just a minute. Uh, okay. Hopefully now my slides are visible.
Yes, yes, it is visible.
Um,
Okay.
I'm making them, yeah, full screen.
Yes.
So
Yeah.
in the next 20 minutes, I shall be talking about inflammation and type 2 diabetes. What is the connection and what is this unique connection? My introduction has already been given by Upendraji, and now I'm moving forward from this first slide. So this is the very ancient definition of the inflammation, what we all must have read in our books of pathology, that inflammation is the part of the complex biological response of body tissues to harmful stimuli like pathogens, damaged cells, or irritants, and is a protective response involving immune cells, blood vessels, and molecular mediators. So this whole process is called the inflammation. So whenever there is any stimulant, which may be any burn, which may be any trauma, which may be any bacteria, which may be any virus, in response of that, our body reacts in the form of the heat, pain, followed by the redness, then swelling appears, and the last, the loss of the functions takes place. And of course, there is a one more feature of the inflammation in the end of after all these features, that is the healing. Sometimes this healing is with fibrosis, sometimes this healing is without fibrosis. So if we really wish to differentiate between the acute and chronic inflammatory responses, and it is very much important to understand, because many of the times we remained in a dilemma that whether this acute response is to be taken as a chronic response, or the chronic response sometimes is mismanaged as an acute response of the inflammation. In this today's period of the COVID-19, we very well understand what is the acute inflammation. We all are reading, we all are talking about the antigens like virus, bacteria, and this antigen, as I already said, maybe a burn, maybe a trauma, which induces the inflammation. And that is the acute inflammation. And that inducement is in the form of the polymorphonuclears, polymorphonuclears, neutrophils, sometimes monocytes like mononuclear cells, which are also known as the macrophages. They come forward. They are the part of the defense system of our body, and which come forward against these things which are coming from the outside, or these attacks which are occurring here. And if we go in the chronicity of all these inflammation, we shall find somewhere these things are arising like that also. If these inflammatory initiations which are being done in our body acutely are not resolved for a longer time, this acute inflammation converts into the chronic inflammation. And our body defense mechanism is not capable enough to kill the antigen, to ameliorate the antigen, then chronic inflammation takes place in the body. What exactly happens in the atherosclerosis, what exactly happens in the occurrence of the diabetes. The initiation takes place from the endothelial dysfunction. Initiation takes place from there is a small attack on the endothelium of the blood vessels. There is a small scarring or a small uh, endothelium disrupture or something like that takes place in the endothelial blood vessels, which later on goes to the dysfunction. Endothelial dysfunction means endothelium is not capable enough to take that insult which is occurring on its wall, and that endothelium ultimately gets gradually converted into the development of the atherosclerosis. Later on, it leads to the cardiovascular adverse outcomes, as well as it also helps in setting in the diabetes in presence of the insulin resistance. Chronic inflammation is usually caused by or usually mediated by the cells like monocytes, macrophages, lymphocytes, plasma cells. And in both kinds of the inflammation, we see that there are some inflammatory mediators are released. In acute situation, they are the histamine and bradykinin, which are the vasoactive
Yes,
amines.
keep
But in the
joining us.
chronic
I've joined.
situation,
I've joined. I'm there.
in the chronic situation,
Yes, I'm
they
there.
are the cytokines, growth factors, reactive oxygen species, hydrolytic enzyme. These are the factors which do not allow the inflammation to be resolved or inflammation to be subsided. And when does this inflammatory response first appear? On the basis of that, we call it acute inflammation once it is coming up immediately. And once it is not being seen immediately, but it is being seen after a few years, few months, or after a few weeks, it's called as delayed onset of the chronic inflammation. And this may last for many years, up to many months, or sometimes throughout life. And after the response over, as I already said, acute inflammation usually subsided with the healing, because once the healing is there, it is called the acute inflammation. It has occurred and it has been resolved. But once the inflammation is not resolved, it keeps on continuing for years to years, then it ends up with the tissue destruction. So if we talk about the role of the inflammation in the cardiometabolic disorder, we can see that atherosclerosis, prediabetes, diabetes, and metabolic syndrome all are the product of this inflammation. Now a question arises, how do I say this and what is the background when I say this? If we go over the molecular mechanism, we can see that a number of inflammatory mediators, which are called as TNF alpha. Now the TNF alpha has been very famous. It is being called by the, it is being called up again and again by the Chyawanprash promoters also. I don't know how can they make it in their product, but it is also being now so much famous and familiar for the people. So TNF alpha, interleukin 1 beta, PF, TGF beta, PKC, arachidonic acid, all are these are the inflammatory mediators and inflammatory markers which are actually activates the endosomal NADPH oxidase enzyme, which helps in development of the reactive oxygen species. At the same time, all these reactive oxygen species are accumulated at one place, and they helps in activation of the NFKB, causing the inflammation. The result of this inflammation takes place in the form of the setting in of diabetes, atherosclerosis, metabolic syndrome. If we see over this graph, which is showing temporal shift in age at the diagnosis of diabetes in the year of 2004, which has been detected by Cures study in the dotted line you can see, and which has been compared with another study which has been done 4 years before of that, that was the NUDS, has been shown through the thick line, and we can see clear cut. In 4 years of this gap, there has been a shift of occurrence of diabetes towards the younger side, means towards the backward. Or we can say, if a person was getting diabetes in its year of 30 to 39 in 2004, 2000, then in 2004, it was getting a bit earlier than that. How much earlier? It was about 4 to 5 years earlier. But this study has been done only in the 4 years of the gap. But we can see here now, in last 20 years, we see that in from 2000 to now, we have shifted the occurrence of diabetes at least a decade or 2 decades earlier than it was before. Asian Indians are 2 to 3 fold higher prevalence of insulin resistance as compared to the other ethnic groups. Diabetes develops at younger age in Indians, at least a decade or two earlier than Europeans, as I have already shown you in the previous slide. How does it happen? Migrant Indians have much higher prevalence of coronary artery disease, and mortality rates of the coronary artery disease is also higher in Indians, even if they are residing in India or they are residing in US or in other part of the globe. Even if they have been migrated from the India, they are on the higher risk of the coronary artery disease. What does this imply? This implies that Indians are having such kind of the genetic makeup which makes them more prone to develop the coronary artery disease and mortality because of the coronary artery disease. And this truth should always be prevailing here, that Indian develops CAD or coronary artery disease at least a decade earlier, because we are developing the factors which are giving rise to the coronary artery disease and other cardiovascular ailments a decade or 2 decades earlier. So obviously we shall be getting the CAD a decade earlier too. And this is very famous slide, and you must have seen again and again in many presentations, the famous slide of the two famous people, Yagnik and Yudkin. And this Yudkin and Yadkin paradox is what? This paradox is showing then, despite having the similar BMI between Indian and Caucasian, the body fat content is very much different. We can see it here. The person who is the Indian having the similar BMI as compared to its Caucasian counterpart, who is the friend of him, but the body fat is almost 2.5 times in that lean and thin young Indian. And if we can see the images of the X-ray images of the body, then we can see here that here again we can see that the bony prominences and the reflection of the bone is very poor in the Indian people. This shows that a lot of fat is there, which is occupying the space or volume of our body as compared to our Caucasian counterparts. If we talk about the metabolic changes in Indian phenotype, we can compare in this way. Here we can see this European phenotype is having the having its skeleton also very strong apart from the fat deposition around it. So therefore the length A and cross-sectional area B, which can be compared with the surrounding fat, is jointly making the metabolic capacity. The volume of the fat mass is equivalent to the metabolic load. But the same thing is not in the Indian phenotype. Here you can see that Indian phenotype is having a very thin length, but we are having very disproportionately large cross-sectional area B of the lean mass, despite having the similar metabolic load or despite having the similar metabolic capacity, we are having the metabolic load much higher as compared to our European phenotype. What we can see it here in this graph, which is being seen in other side of the slide, that elevation in the metabolic load generated by rapid increases in the BMI and adoption of unhealthy lifestyle is not matched by a recovery of the metabolic capacity. So when we talk about the central obesity and its consequent inflammation that leads to the insulin resistance in Indian people, we know that visceral adiposity, visceral deposition of the adipose tissue is a seat of the chronic low-grade inflammation. From a small inflammation, this deposition of the fat starts taking place at our bellies. And what are those things which are promoting or initiating this inflammation? The chimerin and adipokine initiate inflammation by recruiting plasmacytoid dendritic cells into VAT. And that leads to the production of the type 1 interferon. Pro-inflammatory polarization of adipose resident macrophages takes place, ultimately ending up with adipose tissues and systemic insulin resistance, leading to more occurrence of the type 2 diabetes kind of the phenomena. Here, as I already told you, the inflammation contributes to the insulin resistance, beta cell dysfunction, and onset of the type 2 diabetes. And you can see it here, the similar kind of the comparison of high metabolic load. High metabolic load, people like Indians are having excess of the caloric intake, which gets converted into the adipose tissue. And once this adipose tissues initiates the process of the inflammation, where we can see that adipocyte hypertrophy, adipocyte hyperplasia undergoes dysfunction, immune cell recruitment takes place, and adipocyte inflammation sets in, causing the insulin resistance. Where we can see that increased level of the free fatty acid, reduced adiponectin, increased level of the leptin, higher demand of the insulin, and elevated inflammatory markers which are arising out of the immune cell reactivity like cytokines and chemokines are playing an important role in development of this immune cell reactant. But at the same time, we also see that all these factors are also working on the pancreatic beta cells, increasing its stress, increasing oxidative stress, deposition of the more reactive oxygen species, mitochondrial dysfunction, reduced insulin secretion, which ends up with the cytokine production and immune cell recruitment again inside the pancreas also. So there is, we can see the inflammation all across the body, where we can say that islet cells of the pancreas are getting the inflamed, as well as the immune system is also showing all signs of the inflammation which it produces while acting against the foreign body when it causes the inflammation. So again, pancreatic beta cells, when it is directly impacted, it reduces the secretion of the insulin. So insulin insufficiency takes place together with the insulin resistance, which is being generated by the deposition of the adipose tissue, excess caloric intake, or all these things which I already described before. So what exactly happens that inflammation inflammation in macrovascular complications of the diabetes plays a very important role, where what we can see that pro-inflammatory and pro-atherogens mediators may be in the form of the insulin resistance in peripheral tissues like skeletal muscles, in the kidneys, atherosclerotic plaque, maybe, as I already described in the beginning of my talk, that atherosclerotic plaque is the outcome of pro-inflammatory and pro-atherogenic activities inside the blood vessels, which are arising out of the inflammation beginning with endothelial dysfunction. Again, it also works the deposition of the adipocytes in the fat deposition in the visceral tissues. At the same time, it also causes the dysfunction of the activities in the liver, the hepatocyte level, and immune cell level together. What exactly happens in the microvascular complications of the diabetes once the hyperglycemia and hyperlipidemia are occurring together? They cause the accumulation of the glycemic end products, oxidative species. At the same time, they also cause the hypoxia, in which not enough oxygen is reaching to the end organs or the organs which are supplied by these microvascular tissues. Inflammatory signaling cascades is increasing here again, and local activation of the pro-inflammatory cytokines is occurring, causing the inflammation, which ends up with nephropathy, retinopathy, and neuropathy. So what is the potential marker of all these activities? How can we recognize that these activities have started occurring in our body? After getting something set in, after getting the heart problem, after getting the type 2 diabetes has already set in. Obviously, the blood sugar level and the other things which can be the marker for that dysfunction will tell you. But how can we really know that the process of the inflammation has already set in our body? For that purpose, we know that some potential markers like WBC count, serum cytokine markers, interleukin 6, TNF alpha, interleukin 10, acute phase reactants like highly sensitive CRP, C-reactive protein, serum amyloid A protein, fibrinogen, and CD8 T cells, CD4 T cells, and CD19 B cells can also be the potential marker for the low-grade inflammation. But all these are not every time possible to measure in a patient, not available every time. But the two things are easily available almost in all pathological setup or in every city and place. What we can do really to know the inflammatory status of a patient, like WBC count and HSCRP. Do these two things are really having any link of development of the diabetes? Can we really say that these inflammatory markers are predicting the occurrence of type 2 diabetes in our patients or in our population? A number of studies can be enumerated which has shown the baseline inflammatory markers which were measured, and mostly the CRP and interleukin 6, as well as in some of the studies fibrinogen, adiponectin has also been measured, and they have been found to be predicting the occurrence of diabetes subsequently in those patients. What we call that adiponectin, TNF alpha, inflammatory cytokines, and risk and development of the type 2 diabetes has been reviewed in a meta-analysis of the 19 studies, and it has been found that CRP cytokines among the cytokines, CRP is having the highest predictability for the development of type 2 diabetes, having the relative risk of 1.48. Means out of the 100 patient, 148 patient means shall be developing the type 2 diabetes in the increased level of the CRP. Similarly, the TNF alpha is having 101.16 rate. TNF alpha is having the relative risk of 1.16. Interleukin 6 is having the relative risk of 1.32, followed by interleukin 18, which is having relative risk of 1.45, and interleukin 1 beta is having the relative risk of 0.87. So what we can see here that low levels of the adiponectin increase the risk of the type 2 diabetes, and sensitivity analysis strengthened the association of these adipocytokines biomarkers are the predictors of the type 2 diabetes and should probably be measured to target the therapy as well as intervention, and sometimes the effect of the therapeutic interventions can also be measured by measuring these cytokines level in the body of the person. C-reactive protein is an independent predictor of the risk for the development of the diabetes in the west of Scotland coronary prevention study. What we could see here that C-reactive protein has been found to be associated with more than threefold risk of developing diabetes. Highly sensitive CRP and incidence of the type 2 diabetes has also been evaluated among the patients, those who were not having diabetes. And we could see that the increasing tertiles of the highly sensitive CRP at baseline has been found to be associated with an increased risk of developing diabetes during median follow-up period of the 3.7 years. Means today, if the person is having the highly sensitive CRP level high, there are the chances in the subsequent years he may develop type 2 diabetes. The mediators of the inflammation in progression of the normal to type 2 diabetes in Indians, what we could see that we were talking about the HSCRP as well as interleukin 6. What we can see here that the people, those who are having the normoglycemia, majority of the people are keeping their HSCRP within the acceptable limit, but only few percentage of the people, we could see that only 19.8% of the people were having their HSCRP more than 0.3. But in the people, those who were having the impaired fasting glucose, this percentage has been increased more than twice. 46.9% people has developed their HSCRP more than 0.3, or you can say that highest level. But those who have developed hyperglycemia, those who have entered into the type 2 diabetes, you could see the significantly more than 50%, almost two-third percent, part of the patient, two-third amount of the persons were having, like 68.8% were having their HSCRP level at the highest level of the population. Similarly, we compare the level of the interleukin 6, we see that it is gradually increasing from the normoglycemic population to the impaired fasting people and hyperglycemia. It is having the level of serum interleukin 6 highest among the hyperglycemic, those who have got sets in with the type 2 diabetes. HSCRP has also been established as a cardiovascular risk markers in the diabetic. Very nicely in this graph, we can see that cardiovascular risk marker with or without metabolic syndrome. What we could see here, the people, those who were having the highly sensitive CRP level, at the highest level, they were having the metabolic syndrome more commonly as compared to those who were having the least level of the HSCRP. It has been based on the Women's Health Study and West of Scotland Coronary Prevention Study. Again, we can see it here that indicators of the inflammation were closely associated with the metabolic disturbances. HSCRP has been closely associated with the HbA1c as well as with the BMI. But we can see it here. Here at this arm, you can see the HbA1c. And this arm, you can see the CRP level. And this arm is showing you a BMI. And you can see that if the HSCRP level is more than 10, you can see that HbA1c and BMI both are on their highest level of occurrence. High white blood cell count is also found to be associated with a worsening of the insulin sensitivity and predicts the development of the type 2 diabetes. What we could see here that baseline WBC count more than 6,900 per cubic mm had an independent 52% increase in diabetes risk, hazard ratio 1.52, as compared to the lowest quintile where the WBC was less than 5,400 per cubic mm. So even if the WBCs are in the permissible range, they are in the normal range, but the people, those who are maintaining at the high level of the WBC, they remain on the higher risk of getting type 2 diabetes because the level of the inflammation is high among them. Association between basic indicators of the inflammation and metabolic disturbances, as we discussed before, we can see it here that WBC, HbA1c, and BMI, all these are being evaluated together towards the occurrence of metabolic risk as evaluator. Relationship between WBC, CRP, and metabolic syndrome, as in the last slide we had evaluated all these three together. Here we can see that metabolic syndrome component in the Caucasian and African American, we can see there is a significant relationship existing between the inflammatory markers and the occurrence of the metabolic syndrome, may it be in the form of the CRP, may it be in the form of the WBC. Adiponectin also gives its association with the progression for the diabetes, progression towards the diabetes. What we could see it here, that change in the level of adiponectin over 1 year had really caused a difference, and here it has shown a difference in the life of the type 2 diabetic people. What we can see it here, lifestyle itself has created a change in the level of the adiponectin, while the metformin has created a significant, much more changes in the level of the adiponectin, which actually progresses towards the occurrence of the diabetes. If baseline adiponectin level are higher, the progression to type 2 diabetes is slower. What we can see here, TNF alpha expression is elevated in the adipose tissue of multiple experimental models of the obesity. Neutralization of the TNF alpha in one of these models improves insulin sensitivity by increasing the activity of the insulin receptor, tyrosine kinase, specifically in the muscle and fat tissue. And this has suggested a defect at or near the tyrosine kinase activity of the insulin receptor. It gives a clear-cut link between the obesity, insulin resistance, and diabetes. Neutralizing TNF alpha can improve the insulin sensitivity. This is really the message which is being propagated by multiple corners in the society nowadays, taking up a lead from here. So type 2 diabetes is an inflammatory disease leading to insulin resistance and beta cell dysfunction. There are a number of international evidences which have been published in various internationally accepted index journals across the world. From 2001 to 2013, a lot of publications are there. So concluding all these evidences which have been presented by me in these slides presentation, what we can see that prevalence of type 2 diabetes is rising across the world, and of course in India, it is undebatable. Everyone will agree with that. But very few of us were knowing that markers of the systemic inflammation has been critically implicated in the pathogenesis and complications of the type 2 diabetes. So this is also one of the very important way of reducing the severity and reducing the complications of the type 2 diabetes if we could reduce the systemic inflammation by some or other way. Abundant clinical evidences explains role of systemic inflammation in obesity, metabolic syndrome, insulin resistance, and beta cell dysfunction. My co-speaker shall tell us about how can we really reduce this inflammatory load from our body, how can we really do something to reduce this systemic inflammation in our patient, those who are having type 2 diabetes, and of course, those who are not having type 2 diabetes, but may progress towards the type 2 diabetes. Can they really be doing something to so that they may not enter into the type 2 diabetes and they can reducing their systemic inflammation. Thank you very much for your kind listening. Dr. Sandeep Suri is here.
Yes, sir.
I think so.
Yeah. Yes,
Yeah.
sir.
So, Dr. Sandeep,
Good
you
evening,
can
sir. Good evening.
start
Yeah.
your presentation
So,
now.
sir, let me share my screen. Yes, sir.
And if you want to comment anything on my presentation, you are most
No,
welcome.
it's okay, sir. It's fine, sir. Absolutely fine. So we will be doing question answer session after the talk.
Yeah.
This is, let me share my screen.
Yes.
So good evening, friends. My slides visible
Not yet.
now?
Yes, visible.
No.
Visible?
Why not
Yes,
to
yes, it
me?
is visible.
Slides are visible?
Yes, yeah. Now I can see.
Yeah.
Yeah.
So,
Yeah, sir.
fine, sir.
Excuse me, sir. Actually, just give me just 15 seconds time. Let me say a few words for Dr. Sandeep Suri also.
Okay, I will
Yes,
be
yes.
continuing.
Actually, I was not having his CV.
Okay.
Otherwise, I
No,
could
no.
have
Okay,
definitely.
No,
Actually,
issue, sir.
actually,
No issue.
audience, actually, they must be.
Yes, yes.
Yeah.
Okay.
Dr. Sandeep Suri basically is a senior consultant diabetologist from Hisar. Is Advanced Diabetes and Critical Care Holy Hospital, Hisar. He's having almost more than 23 years of experience in diabetes, and currently he's the president of Indian Podiatry Association for Haryana chapter, and he is associated with international societies like ISPAD, ADA, ACE, and all. So this is about Dr. Sandeep Suri. Now request Dr. Sandeep Suri, please, sir. And thank you,
Yeah.
thanks a lot, sir, Dr. Anuj Maheshwari, sir. You played like all rounder as usual. That you play, and thanks a lot. And later on, sir, my request, please, we'll have a question answer session. That time we'll discuss in length, sir.
Sure.
Thank you,
Sure.
sir. Please,
Yeah.
please, Dr. Sandeep Suri, sir.
Yes, sir. Good evening, friends. At the outset, I must thank IPCA for inviting me to come and share a stage with such a learned and esteemed faculty, Dr. Anuj Maheshwari. And he has set the stage very nicely to understand the concept of hydroxychloroquine use in type 2 diabetes. First of all, my heartfelt condolences to Dr. Amit Gupta. He was also a co-speaker with us, but due to demise of his mother, and we pray God to give peace to the departed soul. So coming to my topic, we all know that type 2 diabetes is increasing. It is increasing like tsunami, and you can say it is an epidemic, or even you can say it's a pandemic growth, with incidence just quadrupled in last 3 decades. This is increased maximum in our areas, that means Southeast Asian countries, and it accounts to more than 110% growth rate. Our GDP is going down, we are having lockdown issues, but the growth of this tsunami is unabated. We are around 78 million people with diabetes, and pre-diabetes around 85 million, and 50% of our diabetic population is just unaware of their diagnosis. They are just undiagnosed, and you can see the consequences of undiagnosed diabetes. On the other hand, we have nearly at the same pace the growth as the disease mortality is growing. We are having similar pace of newer and newer molecules, class of drugs added to treat this disease. Things were very easy when we were in post graduations and in MBBS, when we had only insulin, sulfonylureas, metformin, and pios, just 4 set of drugs, 4 set of class of molecules to be used. Now we have around 12 or even more than 12 if you include all injectables and oral glucose lowering drugs. So things are now much more confusing, very much debatable, and there are many CBOTs coming, pushing the drugs. Pharma push is also there. Also, newer and newer molecules are coming from other specialties also, and they are showing potential of decreasing glycemia, and also over and above glycemia, they are showing some benefits. And this is the topic of today's, that is, we are talking about hydroxychloroquine. Also, there are certain drugs like ranolazine that has showed A1C reduction of 0.5 to 0.6%. Then valsartan scabutil combination, which we are using for heart failure, is decreasing around A1C by 0.6%. Also in exchange, we are very generous people. Glucose lowering molecules are now being accepted very warmly by other specialties. As you can see, the DPP-4 inhibitors, they are being picked as a dermatology molecules. Forget about bullous pemphigus, but DPP-4 inhibitor is a molecule for psoriasis treatment. Metformin is a molecule for PCOD treatment, infertility treatment, also longevity treatment. Then providing decreasing aging, also anti-neoplastic drug, pre-diabetic prevention conversion to diabetes, rheumatoid arthritis drug. So metformin has been also very generously used by other specialties. You also know SGLT2 inhibitors, flavor of today's world, cardiologist for heart failure, nephrologist for CKD, and you can say there's gastroenterologist people for NAFLD. So today's talk, we are going to focus on such molecule, which is hydroxychloroquine, and this has been very nicely deliberated by Dr. Anuj Maheshwari, talking about all the inflammation and issues related to type 2 diabetes, increased incidence, prevalence, obesity, overweight. All these are basically chronic inflammatory disorder. So moving ahead with the slide. Now, hydroxychloroquine, if you look at the historical aspect, first US FDA approval was in 1955. Predominantly, it was used in rheumatoid arthritis and lupus. Hydroxychloroquine figures in WHO essential list of medicines. 2001, rheumatoid arthritis. 2006, polymorphic light eruptions, and then lupus erythematosus. So most of the time, this drug has been used for rheumatologists for management of their diseases. And the experience with hydroxychloroquine goes back to even 70 years. From 2014, diabetes DCGI has given approval. CDSCO organization has given the approval, TCHA approval for management of diabetes. Now, what are the mechanism of hydroxychloroquine working in type 2 diabetes? And I will also say that if you look at these mechanism, you will say why we are not using in type 1 diabetic patients. So there are four major mechanism of actions. Number one, it inhibits the insulin degradation. Degradation of insulin goes down. Second, reduction in inflammation. That is chronic inflammation that Anuj sir has highlighted. We call it as a meta-inflammation. That is metabolic consequences of this of this inflammation. So it's a chronic inflammation which is going down by this hydroxychloroquine. Then it improves insulin sensitivity. It decreases insulin resistance and it improves insulin sensitivity. Then there is beta cell preservation. Few of these studies are from rodents or experimental and mechanistic studies, and few of these are replicated in human studies also. So first coming to insulin degradation. Just you have to revise your how insulin is working. Insulin binds to its receptors on the cell membrane, and you know there are alpha and beta part of these receptors. These are alpha part is extracellular, whereas beta is intracellular. By binding of insulin to its receptor, there is tyrosine kinase changes. The tyrosine specific protein kinase changes are there, leads to phosphorylation and dephosphorylation of down regulation of other enzymatic processes. Then GLUT1 to GLUT4, that is glucose receptor uptake receptors. They are basically protoplasmic. They go to the cell membrane surface from where glucose enters inside. Hexose kinase pathway is activated and ATP is produced. And insulin is degraded at the level of lysosomes. And there are four enzymes which are degrading this insulin. One is insulin protease. Number two is glutathione insulin transhydrolase. Then third one is lysosomal protease. And all these three enzymes make the half-life of insulin only very short, that is 4 to 6 minutes only. So what hydroxychloroquine, but for working of this, it requires that pH should be acidic. So by making how hydroxychloroquine works, it binds to this insulin receptors and also towards insulin and insulin receptor complex, and also goes to these enzymes in the endoplasmic reticulum and also at the level of lysosomes. And by this, hydroxychloroquine causes alkalization, resulting in inactivation of insulin degrading enzymes. So the prime response of insulin degrading enzyme, they requires acidic pH inside. If you make the pH alkaline by any molecule, so hydroxychloroquine that works like that, it makes intracellular pH alkaline, and that leads to inhibition of these enzymes. So this is the how the mechanism of hydroxychloroquine working, and it decreases insulin degradation. So less insulin degraded, insulin is released as it is ready to act again. So you can say that concentration of insulin is increased, or you can say half-life of insulin is also increased. So by virtue of these two mechanisms, hydroxychloroquine, this is the mechanistic study. It was shorter study of 10 days only. There is, as you can see here, that as the concentration of hydroxychloroquine is increasing, the percentage of insulin degraded is decreased significantly, and area under the curve for insulin is also increased. So as blood hydroxychloroquine concentration increases, insulin degradation goes down and also blood insulin levels increase. Secondly, looking at the second mechanism, that is hydroxychloroquine reduces systemic inflammation. Now, as an anti-inflammatory molecule, we are well versed with this molecule, as it is acting as disease-modifying agent with methotrexate in rheumatology practice. So it's not a confusion at all, that we all know that it leads to decrease inflammation. This is the study. There is a clear link between type 2 diabetes, hyperglycemia, and increase HSCRP, already alluded to you. So the study showed that if it is HSCRP going down by 1%, it leads to decrease in A1C by 0.8 to 1.3%. This was from Arjun Badya, and the study, it was done in 2018. 120 type 2 diabetic patients were there. They were on insulin, they were on glimepiride plus metformin, and hydroxychloroquine 400 milligram OD was added. And they looked at HSCRP and correlated with decrease in A1C. So 1% decrease in HSCRP leads to significant decrease in HbA1c up to the tune of 0.8 to 1.3%. Now, hydroxychloroquine improves insulin sensitivity, that is, and also beta cell function. Now, to look at insulin sensitivity, they and also towards beta cell function, they used the HOMA model, that is, homostatic model of assessment. And they calculated two indexes. One is sensitivity index for insulin sensitivity, and also then disposition index for beta cell function. It was a small study of 30 patients. Wasco et al. They published this study in 2015 in Diabetologia, and they picked obese, non-diabetic, rheumatoid arthritis patient. They were having pre-diabetes as per ADA criteria, and they showed that there is significant improvement in insulin sensitivity by 20% with the 6-week treatment of hydroxychloroquine. HOMA IR, that is insulin resistance from homostatic model of assessment, after 6 weeks also decreased very significantly. And beta cell function, that is, there is improvement in disposition index by 45% in these obese, non-diabetic, pre-diabetic patients as per ADA criteria. So clearly showing that this molecule has got preventive aspect of type 2 diabetes in rheumatoid arthritis patients who are obese and they are pre-diabetic as per the definition of pre-diabetes. So also, when you look at other fourth mechanism, that is the beta cell preservation. Now you are having this mechanistic study from the rats, diabetes rats, rodents studies there. Abdul Hamid published the elegant study, and it's an experimental rat study with the rats were diabetic, and he termed these as a isletopathy. That is, islets, both alpha and beta cells were having increased markers for interleukin 1 beta, TNF alpha, TGF 1 beta. So they were all increased. And once you started treatment with hydroxychloroquine, there is significant decrease in all these molecules. And specifically, when you looked at beta cells, they were much more sensitive, much more responsive to hydroxychloroquine treatment in comparison to alpha cells. So these are the four basic mechanisms: insulin degradation going down, chronic inflammation going down, insulin sensitivity improving, and beta cell preservation as from the rodent or mechanistic studies. Now, looking at the clinical studies, first Indian phase 3 trial, it was a trial, basically pivotal trial done by Anil Parekh, and this was the trial which paved way for the approvals from DCGI. So Parekh et al., that was published in Current Medical Research Opinion in 2014, and they picked up 806 patients, and from there that they selected 267 patients, and they had two arms. One arm was 135 patients. They used hydroxychloroquine over and above the glimepiride plus metformin, and another arm was pioglitazone 30 milligrams. So here they compared hydroxychloroquine 400 milligram OD dose with pioglitazone 30 milligram OD dose. What they found that nearly equal, you can see that FPG, PPG, and HbA1c value in this study of 12-week and also 24-week. FPG, postprandial glycemia, and fasting plasma glucose, and HbA1c, they were just equal in the both arms. So this was an equivalence study that showed that there is a non-inferiority of hydroxychloroquine 400 milligram to pioglitazone 30 milligram. Now, and also hydroxychloroquine had a favorable effect on lipid parameters. Again, very important input that there is decrease in total cholesterol, decrease in LDL cholesterol, and also significant decrease in triglycerides with use of hydroxychloroquine in comparison to pioglitazone. And also there was marginal weight loss of 1.08 kg with hydroxychloroquine, and there was as inherent increase with pioglitazone of 0.73 milligram with pioglitazone. So these were the other benefits in comparison to FPG, and they were all very clinically relevant benefits seen with hydroxychloroquine in comparison to pioglitazone, despite the equal reduction in glycemia. Now, there are many international studies also, and and this is very important study which I'm going to highlight here. That's a probability of developing diabetes in rheumatoid arthritis patient with hydroxychloroquine. It was a prospective, multicentric observational study of around 5,000 patients with rheumatoid arthritis, and they were not having diagnosis, or they were not on treatment of diabetes in outpatient university-based and community-based rheumatology practice, and it was 21.5 years of follow-up of the study. So here, what happened that uh, you can see from here use of hydroxychloroquine. It was done by Wasco et al. Use of hydroxychloroquine more than 4 years was associated with 77% low risk of developing diabetes. So clearly showing that this molecule has preventive role for type 2 diabetes by virtue of all those mechanisms which we have already uh, uh, so this was a proof of concept study basically, and that led us to think that hydroxychloroquine has got definite benefit in type 2 diabetic patients also, and also in pre-diabetic state. So there are international studies by various authors, and I'm going to just hurriedly looking at the results and important clinically relevant findings here. This was study after 6 months with the addition of hydroxychloroquine. 200 milligram TID dose was given with insulin or glibenclamide group. HbA1c reduced by 3.3%. Insulin requirement also goes down by 30%. So this molecule has got definite insulin salvage effect. Decreasing insulin dose, you know all the benefits which you can encounter with decreasing insulin dose in your routine practice. Another study, 6-month treatment, addition of hydroxychloroquine 300 milligram BD. So the dose was somewhat higher when they used in international studies, but we are approvals dose for Indian standard is 400 milligram OD dose, and decrease A1C decreased by 1.02%. Glucose tolerance and LDL cholesterol improved during the first 3 months of the therapy. Now, this was a randomized double-blind placebo-controlled trial of hydroxychloroquine versus placebo. Patient characterized as HbA1c more than 8%, weight more than 60 kg, type 2 diabetes for 12 months. Inadequately controlled on metformin 1500 milligram and glimepiride 4 milligram therapy. So hydroxychloroquine used as a third line agent, 400 milligram OD in for 6 months versus placebo. Now you can see the very nicely there is improvement in fasting plasma glucose up to the tune of 60 milligram in comparison to 24 milligram decrease by placebo. Postprandial glycemia significantly improved, 135 milligram decrease in comparison to 42 by placebo. HbA1c at the end of trial was minus 1.3, favoring hydroxychloroquine in comparison to placebo. The patient, another study, that patient with HbA1c value of 7.5 to 11 with the maximum tolerated dose of metformin and sulfonylureas. They were on maximum tolerated dose of this. So metformin and sulfonylureas, hydroxychloroquine 400 milligram was added versus pioglitazone 45 milligram daily. So conclusion of the study was that hydroxychloroquine may be beneficial in uncontrolled type 2 diabetic patient as a third line agent. Both drugs were well tolerated, significantly improved glucose control. 400 milligram HCQ reduced A1C value by 1.2% versus 2.8 with pioglitazone. Pioglitazone 45 milligram was somewhat superior to hydroxychloroquine 400 milligram, but up to 330 milligram, they were just equal. Pio caused significant weight gain. You can have that thing in your mind that if you are using pioglitazone, so there is significant up to 45 milligram dose, 3.3 kg weight gain is there with pioglitazone, whereas there is 0.3 kg weight loss with hydroxychloroquine. I think this is very clinically relevant point here. Now, latest international presentation from conferences presented in 2020 ADA specifically, there are Anil Parikh, he has done the job, and also Dr. Manoj Chawla sir and Dr. Arjun Bhatia, they all has given contributed to this. First, moving to Dr. Anil Parikh study, real world study included 1500 patients with type 2 diabetes, A1C more than 7%. They received add-on hydroxychloroquine 400 milligram per day to metformin sulfonylureas combination for 24 weeks. So the mean age was 51.3 years. So 1297 patients completed 24 week of therapy. And you can see here the changes in A1C both at 12 week and 24 week were very significant, up to the tune of 1.1 to 1.4%. A1C fall by 24 week more than 0.5% was in 81% of patients. So the drug was very much responsive in when you combined with sulfonylureas and metformin add-on drug. A1C fall by more than 1% at 24 week were seen in 62% of the patients, and A1C target achieved less than 7% was there in 34% of patients. A1C target achieved less than 8% was there in 73% of the patient population. So this was the largest clinical data, and then and also they looked at the lipid parameters, total cholesterol, LDL, HDL, non-HDL cholesterol, and triglyceride all showed significant benefit at 24 week of the therapy. So, and what about the tolerability of the issue? This molecule, GI side effects are somewhat there. They are 25% increased GI tolerance. GI side effects are there. Adverse events with mild intensity were there, 85%. Adverse event unlikely related to hydroxychloroquine was there in overall adverse events were in that population, but 66% were not related to hydroxychloroquine. Hypoglycemia was seen in 10 patients. All were ADA, minor, mild hypoglycemia was seen in 10 patients. NPDR cases, 9 patients, all were mild. 8 were unlikely related to hydroxychloroquine. So overall, you can see that there is excellent tolerability of this molecule in this real world study. Now, again, the real life use of hydroxychloroquine in type 2 diabetes, now from Dr. Manoj Chawla, sir. It's a 95 patients were 95, number of patients were there, duration of diabetes were more than 9 years. And 51 received statins, 38 were on antihypertensive medications. Efficacy, A1C reduced by 1.05% at 24 weeks. Total cholesterol and LDL also reduced with hydroxychloroquine. So there is an added advantage of adding hydroxychloroquine with statins. Mean body weight reduced from 73.59 to 72. That means around 1 kg and more than 1.5 kg weight loss was there. Safety issue, no case of hydroxychloroquine induced retinopathy in any patient followed till 52 week. One patient was detected with mild NPDR at 12 week and the drug was discontinued. 12 adverse events reported, 11 were mild in intensity, unlikely related to hydroxychloroquine, and no incidence of derangement in hepatic and renal parameters. So these were the detailed results of that study. A1C significantly decreased by 1.05%. FPG, you can see that 34 milligram decrease. Postprandial glycemia, again 41 milligram decrease. Total cholesterol, triglyceride, LDL, and HDL. Improvement of HDL was also seen. So hydroxychloroquine could be a well-tolerated and effective therapeutic option for patients with type 2 diabetes uncontrolled on 2 or more OHAs. So this was the conclusion from Dr. Manoj Chawla, sir. Now from Arjun Vaidya, sir, the effect of hydroxychloroquine plus rosuvastatin on lipid profile and HbA1c of patients with diabetic kidney disease. So real world study of uncontrolled type 2 diabetes with diabetic kidney disease. So these patients, the results was that they were around 67 patients. Triglyceride level were reduced by 25% in hydroxychloroquine. Now it is an added advantage to rosuvastatin to decrease triglyceride, which is a very important dyslipidemia marker, dyslipidemia part, as you can see from it's an Asian dyslipidemia phenotype, that is different phenotype in comparison to Caucasian population or Western counterparts. We have got high triglyceride and low HDL, and a small dense LDL is on higher side with normal LDL levels. So triglyceride, which is a very predominant factor in our scenario. So this molecule has got definite effect on decreasing triglyceride in addition to your rosuvastatin. And the results are somewhat even better. If you can look at the LDL cholesterol fall, then non-HDL cholesterol fall, and improvement in triglyceride, even it is better than combining rosuvastatin or atorvastatin with HDMIB. It is, if you compare these two studies, the amount of percentage decrease in these lipid parameters is much better with hydroxychloroquine combination with atorvastatin and rosuvastatin. So also there is somewhat better eGFR with the use of hydroxychloroquine and improvement in urinary albumin creatinine ratio. So these things, they require to be more elaborated on larger trials, longer trials, but the indications are there that it has got organ protection also, on not only as a glycemia reduction drug, not only focusing only on a glucocentric approach, but more on cardio metabolic, viscerometabolic, and vasculometabolic benefits can be achieved with use of hydroxychloroquine. Now, what are the safety efficacy after this 52-week study? Study enrolled 600 patients of type 2 diabetes, uncontrolled HbA1c on metformin sulfonylureas. They received hydroxychloroquine for 52 weeks. 405 patients completed 24 week, and 234 completed 52-week study. And they looked at the baseline HSCRP, as already alluded to you from Dr. Anuj Maheshwari, that had shown that how HSCRP, highly sensitive CRP, is related to incidence of increased incidence and also increased morbidity related to diabetes, overweight, and obesity. Here they picked up two strata was there, HSCRP less than 3 and HSCRP more than 3. And you can see here those patients who are having high inflammatory load, baseline inflammatory load on higher side, specifically when you have got HSCRP more than 3, their HbA1c reduction, FPG reduction, and postprandial glycemia reduction is much more robust in comparison to those who are having HSCRP less than 3. And if you can just going back few years, that we have got statin trial that showed that if you look at the HSCRP part, the patients who are having higher HSCRP more than 3, they respond better in their lipid improvement in with statin dose in comparison to those who are having lesser HSCRP. So this might be one indicator where we can use this molecule as a first add-on to metformin. It's my own proposition that if you find that HSCRP is on higher side in type 2 diabetic patient, why not to add this molecule? It's a safe, it is a cheaper molecule, it is off patent molecule, and I must congratulate Ipika for doing so many studies with this off patent molecule, which is so much cost effective. And so many companies, they are not interested in off patent molecules, but Ipka is doing good job here. So my proposition is that why not to add it as a first line add on to metformin in these type of patients who are having HSCRP more than 3. So, and looking at the concluding this Anil Parikh study, it's a type 2 diabetic patient who have high inflammatory load, and hydroxychloroquine could be effective and well tolerated option in these population. Look at the total cholesterol, triglycerides, LDL cholesterol, and non-HDL improvements. They are very significant results in patients who are having HSCRP more than 3. Now, can we add hydroxychloroquine add-on to metformin and sulfonylureas as a third add-on? So there are various studies. These are observational studies, and they from various authors from Indian subcontinent. So they are overall A1C. They were all 24-week study. Overall A1C reduction was up to the tune of 0.8 to 1.3%, and there was significant improvement in all markers of patients were reaching at A1C targets less than 7. Postprandial glycemia reduction was there. Fasting plasma glycemic reduction was significantly there. And those patients who are having high HSCRP, their response was much more robust, and there were a much more robust decrease in body weight and in patients who are having baseline high HSCRP. Now, comparison with DPP-4 inhibitors. You all know that both these two molecules, why they are compared? Because they are both insulinotropic drugs. They increase the level of insulin, but they don't stimulate directly the beta cells. In DPP-4 and also SGLT2 inhibitors, they are basically insulinotropic.
Maybe doctor faced some network issue.
I think he's disconnected.
Yes.
So some problem has occurred at the end of his internet, I think.
Yes, correct.
Should we wait, or in the meantime, we should start taking up the questions? Is there anybody to
Yes,
speak him?
they have
Sir,
joined.
I'm back. I'm back. I'm back, sir.
Okay.
So can
Okay.
I?
Great, great, great.
Light issues, electricity gone down. So
No
let me
problem.
share my screen. Fine, sir. So
It
again, I'm
happens in
sharing my
India.
screen. Yeah, yes, sir. So where was I? Can I? So my slides visible?
Yes, yes.
Okay, fine, sir. So we were comparing DP4 inhibitors with hydroxychloroquine, and I was telling that both are insulotropic drug. They are not directly stimulating the beta cells of pancreas, and also SGLT2 inhibitors, by virtue of their glucosuric effect, they are not working on beta cells. So they all three are basically insulotropic drug. That's why they have got very lesser incidence per se of hypoglycemia. Now, if you compare between hydroxychloroquine and DPP4 inhibitor, so let me see. Yes. So this is the comparison, various studies in comparing tenligliptin with sitagliptin and also with vildagliptin. Overall, you can say that HbA1c reduction was somewhat better with hydroxychloroquine in comparison to DPP4 inhibitors. Fasting plasma glucose was also numerically benefit towards improvement with hydroxychloroquine in comparison to your Vilda, Sita, and also tenligliptin. Also, postprandial glycemia was also on better improvement with hydroxychloroquine. So if you are using this molecule in comparison to DPP4 inhibitors, and this is a cheaper molecule, OD dose and no dose up titration is required here. So I think this can be a good option in comparison to DPP4 inhibitors. Now, moving to these are other observational studies showing the similar effect on A1C, better effect of A1C versus gliptins, and also on fasting plasma glucose and postprandial glucose. And all these were 24 weeks duration trials. Now, if you compare SGLT2 inhibitors with hydroxychloroquine, it's a very nice comparison, and it was somewhat more, you can say it was a big surprise for me that if you compare dapagliflozin in type 2 diabetic patient who were uncontrolled on insulin and glimepiride plus metformin, if you compare with dapagliflozin and HCQ 24-week trial, and the patient 35 patient they received hydroxychloroquine and around 29 patient they received dapagliflozin, you can see that HbA1c reduction with HCQ was significantly greater than dapagliflozin. Confirmed hypoglycemia events were significantly less with hydroxychloroquine in comparison to dapagliflozin. No severe hypoglycemia was reported with any of the drug as usual. Reduction in body weight was 2.1 kg with hydroxychloroquine, whereas it was only 1.9 kg with dapagliflozin. So this drug definitely scores over your routine SGLT2 inhibitors. And also you can say that decrease in insulin dose was also very good. That means around 8.2 units in DAPA arm, but here it was 12.8 unit decrease in insulin dose with hydroxychloroquine when you use in combination of in comparison to dapagliflozin. Now regarding canagliflozin has been already always touted or always made as a strongest SGLT2 inhibitors for all glycemia reduction once you are having 300 milligram. And again, here you are comparing 300 milligram canagliflozin. That's the most potent SGLT2 inhibitor in the market till now. So here hydroxychloroquine 400 milligram OD in 43 patients, canagliflozin 300 milligram OD in 44 patients. It was 24-week trial when we used in patients who are uncontrolled type 2 diabetic patient on vildagliptin 100 milligram and metformin 2000 milligram. So already maximum tolerated dose of these two molecules compared hydroxychloroquine or canagliflozin. Glycemic and safety parameters were the two endpoints they evaluated. Look at the HbA1c. very significant decrease, 1.21 in comparison to 1.16 with canagliflozin 100 milligram. Change in fasting plasma glucose was somewhat numerically improved, or you can say that it was nearly same, but postprandial glycemia reduction was somewhat better with hydroxychloroquine. But the molecule is looking so novice molecule. It's a 400 milligram hydroxychloroquine comparing to 300 milligram canagliflozin. I think it's just like a sumo match that you have made in between these two, and the hydroxychloroquine was at par with canagliflozin in efficacy and safety. Now, regarding hydroxychloroquine and insulin dose reduction, so it's again very important to decrease insulin, and this is how I most of the time I use in my practice, that I add hydroxychloroquine when insulin dose goes on a higher side. And I have practically also seen, and Dr. Anuj sir must have seen, that insulin dose goes down by 20 to 30%. Now here, hydroxychloroquine insulin dose reduction, you can see there are various trials from our own researchers, and decrease in insulin dose with decrease in HbA1c was very significant. The dose goes down by around 10 unit to 15 unit per day. So around 40% decrease can be anticipated with use of hydroxychloroquine when you add with insulin, along with no compromise in HbA1c value, better HbA1c. So looking at all these studies and pivotal trial from Anil Parikh, DCGI approved hydroxychloroquine in type 2 diabetes. It was in 28th September 2014, and hydroxychloroquine is indicated as an adjunct to diet and exercise to improve glycemic control of patient on metformin, sulfonylureas, and in type 2 diabetes. I think why not to add with insulin, and why not to use this molecule maybe off label in type 1 obese patient, so where their insulin dose can be on very higher side. When you're using metformin, why not to use this molecule also? So it can emerge as a valuable therapeutic option in the management of type 2 diabetes. That was published by various researchers from India, and this was published in JAPI. And they labeled it that this molecule can be a valuable therapeutic option in patient with type 2 diabetes uncontrolled on conventional oral therapies. So this was also there in ICMR guidelines, and also there in recent RSSDI ESI recommendation of 2020. This was a RSSDI wheel to make proper choices looking at the various glucophenotype of the patient, and the patient-centric approach has been highlighted here. And this molecule has also been included in RSSDI ESI recommendations for 2020. So now lipid lowering effect already has been discussed. Combined with atorvastatin, significant reduction in total cholesterol, LDL cholesterol, and non-HDL cholesterol. And and also looking at antiplatelet action of hydroxychloroquine, it's a heat study. When comparison to when you use this molecule in comparison to aspirin and clopidogrel, you add with aspirin, then you can see that all these which are platelet aggregating factors, or you can say that platelet aggregating pathway, arachidonic acid, ADP, and collagen 1, they are all decreased significantly when you combine with aspirin plus hydroxychloroquine in comparison to aspirin alone. Yes, you have got better results with aspirin plus clopidogrel in some part, but overall you are not losing the battle when you combine aspirin with hydroxychloroquine. And you have seen that rheumatoid and SLE patients who are using as hydroxychloroquine, they have got effect around 77% decrease in incidence of acute coronaries or increase in atherosclerotic path thrombotic events when you use aspirin plus hydroxychloroquine in these patients. And this is CVOT, which is ongoing. Still, we are waiting for the results. Now, looking at hydroxychloroquine safety, so safety issues always come to our mind, but issue is that you must remember that this molecule is different than chloroquine. It is different than quinine. It has got different chemical structure from chloroquine. By hydroxyl group, which is a part of hydroxychloroquine, which is not there in chloroquine, it is there at N terminal. So hydroxyl group at N terminal makes this molecule poor crossing to blood retina retina border, and also it has got fast clearance from the retinal pigmented cell. So overall retinopathy risk is much more lower with hydroxychloroquine in comparison to chloroquine. And if you can look here, that up to 5 year it is less than 1%, up to 10 year it is less than 2%. And what are the patients which should be looked at for increased risk of retinopathy? Those who are having severe NPDR at the baseline or proliferative diabetic retinopathy, using more than 5 milligram per kg body weight of hydroxychloroquine, duration of use more than 5 years, or EGFR less than 45 ml. So these patients are obviously on high risk of retinopathy, but overall you can say that it is less than 1% for 5 year use and less than 2% for 10-year use. But American Association of Ophthalmology in 2016, they gave a screening protocol for first year of use. Uh, they said that SDOCT, that is spectral domain optical coherence tomography and field charting, should be done within first 6 months of use of this molecule, and annual after 5 years of the use. And also Royal College of Ophthalmology 2018 guidelines recommend similar as per AO guidelines, they are same. Now, moving to other adverse events like hyperpigmentation, that can be there in 7.3% patients with use more than 6 years, that can be there. Hypoglycemia, very much less, not itself, it is not a drug which can increase the insulin directly secretion from beta cells. So there is, it's not a insulin secretory effect is not there, only insulin half-life and concentration increase. So this molecule per se don't have any hypoglycemia issue. QTC prolongation is seen, that has been there, but let's see that we will go through COVID and then we look at the this QT prolongation issue, because that was highlighted very recently with COVID epidemic and use of hydroxychloroquine. This was the article which was there in Lancet, and they retracted it because they were not able to get the detailed patient data or detailed all documentations were not able to receive, because this was from a used data from Surgisphere, which aggregates electronic health records, and there is a, you can say there is a confidentiality issues. So they were not able to give this data to them, and they were this publication was retracted. Lancet gave a clarification on retraction that they were unable to complete an independent audit of the data underpinning their analysis. As a result, they have concluded that they can no longer vouch for the veracity of the primary data and sources. So this led to lot many political changes, political issues, debates from the both national and international platforms. So this made this molecule is a highly you can say publicized or highly criticized in recent COVID epidemic. And but the study conclusion was that if you combined hydroxychloroquine or chloroquine with macrolide, was associated with increased risk of mortality and increased frequency of ventricular arrhythmia in hospitalized COVID-19 patients. So this had put many of us who were using this molecule as a prophylactic drug, we stopped these drugs, and we thought that this drug is not doing any benefit but rather more harm. But facts were there. There was no fear. Safety of hydroxychloroquine in COVID-19. There was a meta-analysis, 9 randomized controlled trial of HCQ in COVID-19. They gave patient around 1,000 patients were there. Cardiac toxicity was not reported. Occurrence of QT prolongation and cardiomyopathy was not reported. As ECG monitoring was required when used in combination with other QTC prolonging medication like macrolides, or you are using with other like antipsychotic medications or antiarrhythmic medications. Cardiotoxicity and occurrence of cardiomyopathy linked to older age, female gender, more than 10 years of therapy, high daily dose, and underlying cardiac disease and renal disease. So these things are were the basic issues that led to these cardiomyopathy. So only these were the red flag sites, the signs, you can say that issues related to cardiomyopathy with hydroxychloroquine. So and COVID-19 itself responsible for QTC prolongation and arrhythmia rather than HCQ treatment. We are managing
I think again there is some disconnection.
Yes, and doctor
Uh,
get disconnected due to some
yes, I think
issues.
already it is 6:30 and I have to join other meeting also. In the meantime, few of the patients are also waiting. So if he is really disconnected, we can take the question or he is
Yes,
coming.
he is coming here.
So again, very sorry, very sorry. It's a
No, no, it's okay. Okay. You please finish it
okay.
as
Yes, sir.
soon as
Yes, sir.
possible. Already we are 6:30 now.
Yes, sir. One, I think two, three slides are over. So arrhythmic safety of hydroxychloroquine must to be evaluated once you are giving this drug to COVID-19 patient, because per se COVID-19 can lead to myocarditis and arrhythmia issues can be there. So always look at QTC prolongation. And in our center, what we are doing, what we look at, if your heart rate is between 90 to 110, it's a sinus heart sinus beat is there, then look at the RR interval. In L2, we look at the RR interval and you make it a half of this, and this will give you the QTC. If it is on higher side, probably you may not use it. Otherwise, this is a molecule that can be used. So this is how we look at the RR interval. I think let me have one or more slide is there. So QTC prolongation already dealt. So key consideration for prescribing information, uses in special population. Data was limited regarding the use of hydroxychloroquine during pregnancy, contraindicated during pregnancy and lactation. Safety and efficacy not established in children. Elderly patients are more likely to have decreased renal function. Useful to monitor renal function, but only issue arises when it is less than 45. Observe caution in patients with renal and hepatic diseases. Contraindicated, known hypersensitivity to 4-aminoquinones, quinoline compounds, retinopathy pre-existing, specifically if you have got moderate or severe NPDR or PDR, or if there is a maculopathy issue, then this molecule should not be used. Drug interaction, insulin or other anti-diabetic drug decrease in dose may be required, so somewhat beneficial part that is there. QTC prolongation already highlighted. Antiplatelet drugs, sometime with aspirin, if you're combining, there can be chances of more ecchymosis, gum bleeds, and epistaxis can be there. So you have to decrease the dose of aspirin, or you have only, if you are only willing to use only, then aspirin should be continued. So such patient may not be suitable for your HCQ. And so what are the take-home messages from today's my talk? Hydroxychloroquine reduces A1C in the range of 0.9 to 1.3%. Additional benefits on lipids and marginal weight reduction, they are very good here. CV benefits in rheumatoid arthritis patient, it reduces CV events. Oxy trial, we are waiting for that. In which patient to use? Can be started in any patient, inadequately controlled on 2 or more than 2 drugs, including insulins. Real risk of retinopathy after 5 years is only 1%, and after 10 years, it is less than 2%. American Association of Ophthalmology recommends initial ophthalmological evaluation within 1 year of the starting of this molecule, and it should be a proper visual field charting. In absence of risk factors, subsequent ophthalmic evaluation can be done in patient receiving HCQ for more than 5 years. And if used for more than 5 years, we should include spectral domain optical coherence tomography in annual screening also. So I stop here and I thank you all for patience listening, and I apologize for the electricity edges. So we can go for the questions if there are.
I think it was a very good and wonderful presentation, quite elaborated. So we can take the questions of the attendees before we conclude the program. There is a one question which is asking that hydroxychloroquine in uncontrolled type 2 diabetes with sepsis, any additional benefit? Would you like to say something about
Sir.
this?
Yes, sir. Sir, sepsis, I think you are in hospital management of hyperglycemia. So I don't think any oral anti-diabetic drug that should be used in such type of patients. If they are there in ICU or HDU, it is to be insulin. Whether you are using basal bolus regimen or you are using continuous insulin infusion, it should be with insulin. We should not go with any drugs. So I don't think it will go give you any benefit, rather
I
it will
think
more.
the person who is asking, he is taking in another spirit that sometimes we continue the oral medication what the patient is taking before entering into the
Okay.
hospital. We add up the insulin there, and he tries to ask that if we also add the hydroxychloroquine, will it have any beneficial effect on reducing inflammation while patient is in the sepsis? So this must be
Uh,
the
okay.
idea behind.
So I think we should go with the insulin, because insulin itself has
This is
got
quite hypothetical, I
anti-inflammatory.
think so.
Yeah.
And we
So
shall we shall
we should.
we shall have to wait some
Yeah.
trials and some kind
Yes,
of
sir.
the studies which must
Yes,
have been done in hospitalized patient.
yes,
Then
sir.
then only anything can be
We can
said
conclude. Yes, sir.
whether it can be used in such kind of the patients or not.
Yes,
So
yes.
that can be asked to him. Another
Yeah.
one is that. Uh, this question is really very, I don't think how should it be taken up. Can hydroxychloroquine 400 mg reduce pill burden in type 2 diabetes patient when add
Yeah.
on? How can you reduce the pill burden once you are adding
Yeah.
up the pill? It's very difficult
Yeah.
to say.
Yeah. There is. Yes,
And
sir. There is no
yeah,
fixed dose combination with any drug.
yeah, yeah,
So it is again a new drug to be added. So I cannot. We cannot
yes,
reduce
yes.
pill burden.
Yeah, yeah. So it's very one thing can be said in answer of this question. What I can understand that definitely by adding up the hydroxychloroquine in a patient who is taking metformin as well as glimepiride or any sulfonylurea, dose of the
Yes.
sulfonylurea can go down in due
Yeah.
course of the time. And in fact, we should be watchful for that also. That if the patient is requiring less sulfonylurea, if hydroxychloroquine has been added up. So this thing must be taken up mind, but pills will definitely be reduced or not. It is quite questionable. Dose may be reduced, but pills will be reduced or not. 4 milligram glimepiride, maybe 3 milligram or 2 milligram glimepiride, but
Yeah.
whether it will be really withdrawn, this is questionable.
Yeah.
Second thing is that another question is that it is
Yeah.
specifically asked to you, Dr. Suri.
Yes. Yes, sir.
Any benefit for combining SGLT2 inhibitor or GLP-1 analog with this hydroxychloroquine? He want to ask that if hydroxychloroquine is to be added to the GLP-1 analog or SGLT2
Sir,
inhibitor,
sir.
then we can
Yes.
get some additional benefit.
Yes, yes. If you look at the, sir, comparative data, then between SGLT2 inhibitor versus HCQ, there is no and there is GLP-1 has never been compared with the HCQ. If you look at comparative data says that if you can combine SGLT2 with HCQ or GLP-1 with HCQ, you are going to get benefits in glycemia reduction. You are going to get benefit in dyslipidemia, lipid control also, and also weight benefits will be there. With GLP-1, the GI side effects should be an issue when you are looking at this. With SGLT2 inhibitors, again, it's both drugs can be combined very nicely. Till now, we have comparative data with SGLT2 inhibitor. We don't have any comparative data with GLP-1 log, and also we don't have any studies when they were used as a combination, as a or an isolated or in a combination in type 2 diabetic patients. But obviously, this gives a one indication that these drugs, this molecule can be combined with these two also, in with getting very positive results.
Yes, very correctly narrated by you. We do not have enough data or any evidence if adding up this molecule to the SGLT2 inhibitor or GLP-1 receptor analog can really makes any benefit in the outcome what we are already getting with the GLP-1 receptor analog or SGLT2 inhibitor. Because SGLT2 inhibitor as well as GLP-1 analog both are supposed to be reducing inflammation also. Whether this will add up, one thing can be thought about that, but it's again would be very hypothetical. In SGLT2 inhibitor, many people develop the genital infections and many people develop the UTI. In those patients, if we give any medication which is reducing the inflammation, probably it will be masking the problems which are already there. Patient may
Yeah.
not be having the complaint, but this will not be again good for the patient.
Yeah.
So we shall have to be quite watchful and quite vigilant for while we are using these kinds of the things, these newer drugs with the hydroxychloroquine especially.
Yeah. Yeah.
There is one question, can it be used in PCOD?
Okay.
Dr. Suri, would you
So,
like to say?
yeah, yes, sir. So there is a, if you look at the decrease in inflammation, inflammatory marker, chronic inflammation going down, weight also going down, lipid parameters improving with hydroxychloroquine, yes, you can use PCOD, but there is no trial looking at, because it is only just like metformin, it is working here, but the drug is it's a category C drug for pregnancy, not for also for lactation. So uh, till now we don't have any study with PCOD uh, in hydrox. You may look at, we will try to look at the data from rheumatology if they have got some studies with the. I'm not aware of any study with PCOD, but mechanistic, if you look at the mechanism of action of the molecule, the drug shows some benefits in PCOD part.
In nutshell, it is not meant for the PCOD.
Yeah.
If we are using PCOD, if you are using this drug for some other indication and PCOD is also there, you can continue with this drug. But this drug is
Yeah.
not really meant for treatment of the PCOD, neither on label nor off label. So don't think to treat PCOD with this drug only. And there is another very good question coming up. Hydroxychloroquine reduces the insulin resistance. It should be used early rather than late. So should not be kept as a last resort. It should be started after metformin. I don't think it is kept as last resort, but after metformin or after sulfonylurea, this can really be a question which comes in the mind of many of our colleagues. Would you like to say something?
Yeah, so same. It's absolutely accurately you have told that we should not wait. We should not make it as a last resort, and it should be much more promoted in our armamentarium for management of type 2 diabetes, looking at chronic inflammatory stage, specifically if you have got high hsCRP in your patients, dyslipidemia is there, insulin resistance is there, and so I think it should be more actively promoted in the uh, protocol for management of type 2 diabetes.
Yes, you are very correct. But unfortunately, the official statement, what I can say it here, that DCGI has approved it only to be used in the patient, those who are already unresponsive to the metformin and glimepiride. Or not only glimepiride, sulfonylurea. Sulfonylurea and metformin combination, and patients are not responding. But now the scenario has changed. Many patients are not being given sulfonylurea. Before that, they are being given DPP-4 inhibitor. Some patients are also being given SGLT2 inhibitor or GLP-1 receptor agonist. So now the picture is changed. But what the DCGI recommendation is there, we should be very safe if we shall go with that recommendation only, instead of being more innovative by ourselves. Let us wait for the more data, so that it can be used just after metformin or even before metformin. If we go on the data what has been presented by Dr. Sandeep Suri and by me, then many of us would agree with this thing, that hydroxychloroquine can be a drug in the pre-diabetes also, because we have seen the patient, those who were using this drug for the rheumatology reason, they have been delayed their diabetes as compared to those who were not using. So there has been a study. So already it is proven that it delays the diabetes if it is given in the pre-diabetes. So why to say that it should be given after the metformin? It should be given before the metformin, but there should always be kept a line between what should be done and what is to be done, that our drug authorities, our authorities which are giving us the permission to use the drug, we must keep their recommendations in our mind whenever we are using drug. So as of now, it is recommended only in those patients who are unresponsive to metformin with the maximum tolerant dose, as well as sulfonylurea with the maximum tolerant dose. So this is the recommendation of the day. Tomorrow what will happen, we all has to wait, and we'll be very happy if it elevates its level in the treatment paradigm or algorithm. So I think with this comment, we are already very late, so we can conclude this. Dr. Suri, if you want to add anything, you are welcome. Otherwise, we can
just
finish
I want
this.
to know what about ACP conference of ACP. Just recent, it's going to be there.
Yeah, ACP conference. already has the national conference has already been done on the virtual platform in the month of August,
Yes,
and
yes,
now we
yes.
are planning to have a Asia ACP Con, in which all the neighboring countries like Sri Lanka, like Bangladesh, Japan, China, Korea, they all will be participating, and this will also be on the virtual platform, and this is planned to be on the 6th and 7th of February.
Okay.
And as of now, I am governor-elect only, not full-fledged governor. In April, 28th April onward, I shall be taking over the charge of the governor ACP. Then probably I will be able to tell you more about the ACP.
Okay.
So till then, wait from my side. Otherwise,
Okay.
our
Right.
leader, Dr. Muruganathan, is doing very
Murugathan
well.
is there. Yes.
We
Yes.
all can approach him for all our
Yeah.
answers to be getting.
Fine.
So
Fine.
thank you very much.
Fine, sir. Fine.
So we'll be
Thank you, sir.
looking again and again, looking to meet you again and again.
Yeah,
Upendra ji,
sure.
thank you, Ipka,
Thank you.
for giving
Thank you,
us
sir.
this
Thank you
forum
very
and
much.
opportunity.
Thank you.
Yeah,
Thank you.
thank you, sir. Thank you very much. Thank you, Dr. Sandeep Suri, and thank you, Dr. Anuj Maheshwari. I know busy schedule, sir. Since morning, Dr. Sandeep Suri was busy in some workshop, diabetic workshop, and about you
NIS,
can't say
NIS is going on.
yeah, because getting and Dr. Anuj Maheshwari's time again a very great
Yeah.
thing.
Yes.
Somehow we have got
Another
his
meeting
time.
is to be started at 7 p.m. and in
Right,
between,
right.
I have to see 2-3 patients also.
Yeah. And one promise I can do here, sir. I'll speak to the attendees. If any feedback, anything, any question in their mind, I'll come back to both of you. And definitely we'll meet
Fine.
again, sir. And thank you
Yes.
again. Thank you very much for your time, sir.
Sure.
Thank you very much, sir. Thanks a lot, sir.
Okay.
Thank you, sir.
Okay, thanks.